So it's now 6:31. I'm Gordon Ngai and will be the moderator for this session, which is the oral presentation for abstract orals of health policy and health services research 2. Today we would have 4 abstracts or 4 oral presentation by 3 presenters. We will start with Dr. Christopher Han, and from Minnesota, and then we would have, let's see, the next one should be Dr. Charlene Swan from Penn State, and then we would have a double from Dr. Alexander Yankee. All right. So when you're ready, Dr. Christopher Han, you can start.
Thanks so much, Gordon. I think that might be the first time that I'm called Dr. Han. I'm almost there. I'm a medical student, a fourth-year medical student at Yale. I want to thank everybody for joining, and I'm excited to share our group's work on understanding EM clinician participation and performance in the merit-based incentive payment system. I don't have any relevant relationships or financial disclosures to make. Our senior author, Dr. Venkatesh, holds a contract with CMS to develop quality outcome and efficiency measures and rating systems. And I'd also just like to take this opportunity to thank all the collaborators and co-authors on this abstract listed here. So starting with the executive summary, the merit-based incentive payment system is the latest evolution in the Centers for Medicare and Medicaid Services evolution away from strictly fee-for-service clinician reimbursement towards value. With its implementation, it became the largest pay-for-performance program in the history of US healthcare. Emergency medicine clinicians participate primarily in groups or another multi-practitioner designation called the MIPS alternative payment model, or MIPS APM, rather than as individuals. And those who report as individuals earn lower scores and resulting payment adjustments. And finally, EM clinicians who use data registries to report their measures generally score higher than those who use the CMS measures designated for emergency medicine. I'll touch on each of these in more detail as we go through the next slides. Starting with the background, over the last 2 decades, there's been an evolution from fee-for-service reimbursement towards value-based care, or the idea of paying for healthcare quality versus solely volume. Quality measure development was followed by voluntary opt-in quality reporting for bonuses, which is then followed by this kind of more recent age into mandatory reporting in the MIPS, resulting in budget-neutral payment adjustments. Other specialties have examined clinician MIPS participation and performance, like in ophthalmology, otolaryngology, radiology, and dermatology. And we want to do this in emergency medicine to understand the performance and how people are participating. The composite MIPS score is comprised of 4 performance categories. The most heavily weighted is quality. And this analysis is the first that we know of to examine the performance of clinicians by these quality measures they submit, and if these measures are from or maintained by CMS versus other registry entities. So our objectives were pretty clear. We wanted to evaluate how clinicians participate in the MIPS and then assess how EM clinicians perform with respect to those reporting decisions, like the reporting affiliation and their measure selection. For methods, we use the free and publicly available CMS 2018 QPP experience report data. This was released in the fall and represents the most recent data available for the program. So even though we're in performance year 2020 and 2021 now, this is released on a delayed basis. By the nature of the data, it was a cross-sectional analysis, and we limited the samples to clinicians listed in their specialty as emergency medicine. We used fields available in the data set to stratify by reporting affiliation, meaning that a clinician was either reporting in as an individual, as part of a group, or as part of a MIPS alternative payment model, which means that they participate in a particular CMS designated model that holds providers accountable to cost and the quality of care provided. For our analysis of performance by quality measures, we categorize measures by their sources, either from registries or from the CMS QPP emergency medicine specialty set or general CMS quality payment program measures. For our results in terms of how EM clinicians participate in MIPS, we found that the majority of EM clinicians participate in groups or MIPS APM, as you can see from that 100% horizontal stack bar at the top. We find that the size of the organizations for individual reporting clinicians are generally smaller, but individuals were not more likely to be in rural areas or practicing in health profession shortage areas than groups or MIPS APMs participating clinicians, which was initially a concern by CMS, knowing that there could be some kind of structural disparities for groups that are either rural or in HPSAs. When we examine the performance by reporting affiliation for EM clinicians and MIPS, we find that on the left-hand side, we've charted the median composite MIPS score and interquartile ranges by these three reporting affiliations. We see marked differences between those reporting as individuals versus those reporting as groups or MIPS APMs, which are scored actually on a different standard, but placed in the same pool for comparison and then ultimately for payment bonuses or penalties. You can see that the median for individuals is 30.8, groups 88.4, and almost all MIPS APMs receive a perfect 100-point score for the composite score here. On the right-hand side, we've charted the shares of payment adjustments by reporting affiliation. The first takeaway is that the vast majority of EM clinicians receive positive or exceptional payment adjustments. However, individuals are assessed on an outsized share of neutral and negative payment adjustments. Here we see that nearly 20% of individuals receive negative adjustments, and individuals represent more than half of all negative payment adjustments, while groups and MIPS APMs receive positive or exceptional adjustments for almost all. For our analysis of measure performance, one major decision that clinicians must make is which measures to report. Measures can really come from three major categories. Qualified clinical data registries are maintained by private entities, oftentimes specialty societies that develop these measures, and groups can subscribe to these data registries for submission. They can also select general CMS maintained measures, and CMS has divided these up into specialty resonant measures, so the EM specialty set, which should be more relevant towards EM practice, and then just general QPP non-specialty set measures. For brevity, we just list the most popular measures by each of those three categories here. In each box, we listed the numerical score of each measure by EM clinician decile and color them according to a heat map. Higher scores correspond to greener values. So in each measure row, the more green, the better the EM clinician score relative to the entire clinician population that's reporting into MIPS. We find, interestingly, that EM clinicians scored more poorly on popular EM specialty set measures compared to the registry measures or the general QPP measures not specified as part of the EM specialty set. So in conclusion, we have three major findings and then kind of two high-level implications that we're going to try to keep simple here. Certainly, there's a lot more to dive into, and we are welcome anybody who wants to do that on email or offline. While there are relatively few of them, individuals earn lower scores than groups or MIPS APMs, and this was driven by variation in the quality category. Number two, this translated into payment adjustment differences. Despite a high propensity for EM clinicians to receive positive adjustments, individuals were more likely to receive neutral or negative payment adjustments. And three, EM clinicians performed worse on the EM specialty set measures for the quality category compared to registry or non-specialty set measures. The implications of this are twofold. One, reporting affiliation matters. Groups and MIPS APMs perform better than individuals. MIPS APMs perform even better than groups. As the scoring curve becomes less generous in the coming years, it'll be important to organize to achieve these best scores. And CMS should also consider accounting for these differences in scoring, like taking the MIPS APMs that are scored on a different standard, but again, pooled against individuals and groups. Number two is measure selection matters. And investing in registries or opening access to those measures for more clinicians may be a good idea. Additionally, there may be a need to revisit the EM specialty set because EM clinicians counterintuitively receive lower scores on these measures compared to the general QPP measure set. Just want to thank you all for your time. And again, any questions, we're happy to field and discuss this more. Thank you.
All right, thank you, Christopher. We have about 2 minutes before the next speaker. If anyone have any questions, I'm monitoring the chat as well as you can ask it here.
So Chris, I have a question. My gut reaction to the, the individual QPP scores being lower is that it's probably because individuals are more likely to report those and groups are more likely to be part of CEDAR. I'm just wondering if, is there a correlation there? Are you sort of the groups that are scoring really well are all part of a clinical quality registry anyway, would you say, or?
Yeah, I think that's a really good question. So one thing that we did do as outside the scope of this abstract is to run a regression to look at kind of all of these features in the data set. And we find that participation in registries does result in higher overall MIPS scores. And and higher resulting kind of payment adjustment category, higher propensity for that. So we find that there is a correlation between being part of a registry. Whether or not that's related to their reporting affiliation, we see that as a separate estimate, and we find that, again, this even being in an individual, regardless of that beta coefficient for QCDR use, is lower.
Yeah, this is great stuff. This is going to be increasingly relevant as the years go by.
All right, I believe we should have a few minutes at the very end. So we'll move on to our second presenter.
Thanks, everybody.
Yeah, it's Dr. Charlene Swan, and the topic is association of emergency department crowding with inpatient discharges. Charlene, you're still muted.
Okay, thank you. I'm an assistant professor in the Department of Health Policy and Administration at Penn State, and I welcome any questions or comments via email or also Twitter. And I have no disclosures to make. So emergency department crowding is associated with poor quality of care and outcomes for ED patients and also patients admitted from the emergency department. But as the COVID pandemic has shown us, the emergency department and the inpatient units are connected. And less is known about how emergency department crowding influences patients who are already admitted. So there are two possible ways that ED crowding can influence inpatients. First is through active bed management. So in active bed management, bed SARs will discharge stable inpatients to make beds available for admitted ED patients. If active bed management works well, we would not expect to see any negative consequences because they're focusing on discharging stable inpatients. But if it doesn't work well, or if the bed SARs have to make difficult triage decisions, we might expect to see that discharged inpatients might revisit the emergency department and be readmitted when the emergency department is crowded. The second route is through physician and nursing workload. Specifically, ED crowding increases admissions, and increased admissions and turnover has been associated with increases in physician and nursing workload, which in turn has been associated with lower inpatient quality, higher morbidity, and higher mortality. And this influence on workload might be particularly challenging if hospitals engage in full capacity protocol where patients are admitted to the next appropriate bed. So our research question was, how does ED crowding at discharge influence already admitted inpatients? And we looked specifically at 4 outcomes: inpatient length of stay, in-hospital mortality, 3-day ED revisits, and 30-day readmissions. Our first hypothesis, looking at the route of active bed management, was that when the ED is crowded, inpatient length of stay is shorter and ED revisits and readmissions are higher for patients who are discharged on those days. Our second hypothesis, which went the route of the workload, suggested that when ED is crowded, inpatient mortality would increase. To test these hypotheses, we used California all-payer inpatient ED data from this that we obtained from the state, which we matched to data on hospital characteristics. And our sample consisted of all inpatient discharges in non-federal general medical hospitals with emergency departments. We excluded the smallest hospitals, those with fewer than 50 discharges per year, in order to increase the representativeness of the sample. We also excluded patients who were transferred to other hospitals and, except for the mortality income, patients who died. And the outcomes we looked at were length of stay, which we log transformed because of the skewness, in-hospital death, and 3-day ED revisits and 30-day readmissions. The ED revisit and readmission variables were all cause and to any hospital. Our main predictor variables, we had 2. They were both reflected ED census on the day of or the day before discharge, and they were categorized as below median, 50th to 75th percentile, 75th to the 90th percentile, and the 90th percentile and above. And it was calculated for each hospital year. And our analysis was linear regression with robust standard errors, using with our primary regressor, again, being the ED census. Age, sex, Alex-Hazard comorbidities, whether admission was through the emergency department, MS-DRG, discharge on weekend, quarter, year, and hospital fixed effects. And we stratified this by whether the patients had scheduled or unscheduled admissions. Because our sample was so large, we had a lot of statistically significant results, and I'm happy to talk about this either offline or in Q&A. But just to note that most of the differences that we found were statistically significant. When we looked specifically at our first outcome, which is the association of ED census on length of stay, this graph shows how mean length of stay for inpatients was associated with changes in ED census, both on the day of discharge and also the day before discharge. I'll start by discussing the blue, which is the full sample. Note that there's a dose response, whereas ED census increases on the day of discharge, length of stay goes up. Conversely, as ED census increases on the day before discharge, length of stay goes down. Specifically, mean length of stay is when the ED census is in the 50th to 75th percentile compared to below median, is 0.3% longer, 0.6% longer if in the 75th to 90th percentile, 0.8% longer when at or above the 90th percentile. And the day before, we see the opposite reaction. It's 0.3% shorter when the ED census is in the 50th to 75th percentile or in the 75th to 90th percentile compared to below the median, and 0.7% shorter when above the 90th percentile. We see the same trend for unscheduled admissions and also for scheduled admissions, although there's a more pronounced effect for the scheduled admissions. When we looked at the probability of in-hospital mortality, again, I'm going to focus on the full sample first, which is in blue. We saw a 0.04 percentage point or 1.8% more likely to die when ED census was at the 50th to 75th percentile compared to below the median. 3.2% more likely to die when the ED census is at the 75th to 90th percentile, or 5% when at or above the 90th percentile. And if we look at ED census before the day of discharge, you're 2.7% more likely to die when ED census is at or above the 90th percentile compared to below the median. And we see the same trends for in patients with unscheduled admissions, although not those with scheduled admissions. We did not see any difference in the probability of 3-day ED revisits after inpatient discharge. And for readmissions, we saw lower readmissions when the ED census was higher. Specifically, compared to when the ED census on the day of discharge was below the median, readmissions were 0.06 percentage point or 0.5% lower when at the 50th to 75th percentile, 1.5% lower when at the 75th to 90th percentile, and 3.9% lower when it was at or above the 90th percentile. Compared to when the ED census on the day before discharge was below the median, readmissions were 0.7% lower when in the 50th to 75th percentile, 1.2% lower when at the 75th to 90th percentile, and 3.5% lower when it was at or above the 90th percentile. And we see the same trend for patients with unscheduled admissions, but only for scheduled admissions for that was the 90th percentile the day before discharge. So in conclusion, what we found was that when the ED was crowded, contrary to our hypothesis, we found that inpatient length of stay was slightly longer, although not clinically significant way. We also saw lower readmissions, which was 3.5% when the ED on the day of discharge was at the 90th percentile. Just to compare, previous studies have suggested that, for instance, the Medicare's hospital readmissions reduction program resulted in a 2.5% reduction in readmissions of targeted versus non-targeted conditions. The 3.5% that we found and the 2.5% reduction isn't directly comparable because we have different populations, data, methodologies, but just to give you a sense that this lower readmission rate might be clinically significant. Consistent with our hypothesis, we found that already admitted inpatients were more likely to die by 5% when ED census was at the 90th percentile versus below the median. So there, post hoc, we started thinking about reasons why we found what we did, and what we think might be going on is that, as we previously predicted, that increased workload leads to higher mortality. But the reason why we might be seeing the length of stay differences is that maybe it also increases the length of stay for patients who are less sick. And we might be seeing lower readmission rates because discharged patients might be more stable because of active bed management. Maybe the active bed management is working well. Our study's limitations, we're limited by the fact that we have hospital discharge data, and our study may have limited generalizability, although I will note that California makes up 12% of the United States population. So even if the results don't generalize, they're still an important finding. And then in conclusion, our study supports the idea that ED crowding is a whole hospital problem. So previous research suggests that ED crowding is caused by a lack of inpatient beds. And this study suggests that ED crowding can also have consequences for the quality of inpatient care. It suggests that ED crowding may be part of a feedback loop where inpatient care influences ED crowding through bed availability, and ED crowding influences inpatient care perhaps through hospital staff workload. So future research should try to understand the causal mechanism behind our findings. I wanted to thank the co-authors on this paper, Joel Siegel, Renee Shaw, Yinan Wang, and Jeanette Rogowski, and also our funders. Thank you.
All right, thank you, Charlene. We have about a minute if there's any quick question. Charlene, I have a question about borders. Like, did you mention, are they counted toward the length of stay of the hospital stay?
Yeah, so you're talking about for a definition of inpatient length of stay?
Correct.
So these are patients who are already admitted into in the hospital. Mm-hmm. So they are, we're just looking at what does the ED crowding look like the day that they're discharged. They're patients that have, they may have come in through the emergency department, they may not have, sort of what happens. So the time that they spent in the emergency department, we do count as part of their sort of time in the hospital.
I see. Okay, so borders are part of the time they spend in the ED that are part of the time as the inpatient.
Correct. Although I don't know that, since we didn't specifically look at what happens on the day that they were admitted, maybe it's possible that, as you might be implying, that, if the ED is crowded both on the day that they were admitted and the day that they were discharged, that we might be coming up, sort of finding some sort of effect. Although I will say that we've examined ED census at sort of a random sample of hospitals, and we haven't noticed any autocorrelation between ED census of various days. We see that the only thing that is a day of the week, and that's something that we control for.
There's one quick question in the chat. Did you stratify patients based on their severity or illness, or why they were admitted?
So we controlled for MSDRG. So there was a we controlled for the DRG that they were for the diagnosis that indicated sort of the reason for admission, and then in terms of why they were admitted. Part of the reason why we stratified based on scheduled and unscheduled admissions was to see whether or not we might see a difference based on, if it was some kind of an emergency type admission likely through the emergency department, or whether it was scheduled, a scheduled procedure, etc.
Okay. All right. Thank you, Charlene. We have to move on. If you have any question, please email Charlene with the email address that she posted. All right, so next we have Dr. Alexander Yankee. and from Yale, and will be 2 presentations. We would pause in between for the questions. The first one would be emergency department visits for acute surgical conditions before and after COVID-19. Go ahead.
Okay, so can you guys see my slides here?
Yes.
So my name is Alex. I'm a PGY4 in emergency medicine at Yale. And next year I'm staying for a health services research fellowship. One of the things that I think all of us have been forced to think about during the pandemic, especially last April, was sort of what happened to all of the patients. So for a lot of emergency departments all over the country, things were very quiet. I remember back in April for a few weeks, there wasn't a whole lot to do except take care of really sick COVID-19 patients. So I've been thinking a lot about changes in care-seeking behavior during COVID, and that has kind of opened up a couple of these questions here that we've tried to tackle with some data from the Clinical Emergency Department Registry. So this first project, emergency department visits for acute surgical conditions before and after COVID. And so there's existing work that we know that the sort of mix of surgical conditions in the hospital changed a lot during the COVID-19 pandemic. And you can imagine there would be lots of potential reasons for that. It might be the case that we're doing sort of fewer surgeries, and so you might expect there to be fewer complications from surgeries. There might be a change in the underlying incidence of certain conditions. And then you might expect that some surgical conditions are sort of more amenable to expectant management than others, so that changes in care-seeking behavior precipitated by COVID, you might think that there's a difference in how those shake out. So for this project, we sort of hypothesized that if we look at a national sample of emergency department visits, we hypothesized that there'd be a greater decline in ED visit rates for diverticular disease and bowel obstruction than for appendicitis and cholecystitis. So this is data from the Clinical Emergency Department Registry. So like Chris was talking about in his presentation, this is one of those national clinical quality registries. This is maintained by the American College of Emergency Physicians. And what we have right now is visit level data for 400 EDs, 403 EDs in the country through the end of 2020. And what I can see is the diagnosis code associated with that ID. And we sort of merged that with some county level data from the University of Maryland's sort of public COVID-19 impact analysis platform. Basic information about COVID-19 cases per capita, hospital bed utilization, case fatality rates, just so that we know a little bit about sort of what's happening with COVID in these places. So these are the 4 surgical conditions that we identified by the ICD-10 code that is assigned to the ED visits for these 403 emergency departments: diverticular disease and bowel obstruction, appendicitis, and cholecystitis. And this is sort of the root of the ICD-10 code. So within that, not always, but often there is some specificity about the particular condition. So for example, appendicitis with or without perforation, with or without abscess or peritonitis. So what we did is our outcome is like the weekly count for each of these 4 conditions. And then we sort of compared the visit counts over time, plotted them using this tool called LOS, locally weighted scatterplot smoothing. And then we stratified the sample by different census regions of the United States in order to test how the ED visit counts changed over time. We wrote a Poisson regression model. So the outcome is the ED visit count. And then there's this variable that goes into it, which is sort of what time period you're in. So the pre-pandemic period is the reference category. And then we have different months of the year. This is just some information about what emergency departments we're talking about, where these places are and how big they are. And then there's just a little bit I want to highlight here. So the sites that we have in Cedar are small sites, around 30,000 per year is the median visit volume. And then in this particular category, we have some of the county level data and COVID-19 characteristic data with 10.6% African American in these counties and 62.4% hospital bed utilization overall. This is kind of the mainline result here. So what we're looking at is 2019 and 2020, a scatter plot for the weekly counts, and then that smoothed, that lowest line for each of the periods. And the first thing that I noticed when I sort of look at this picture is the difference in the raw counts. So bowel obstruction and diverticular disease are much more likely to be reported. So between 800 and 1,000 weekly diagnoses of these conditions in the full sample versus 300 or 500 cases of cholecystitis and appendicitis. And you can see there's just it's really striking drop off in the count of bowel obstruction and diverticular disease presentations to EDs nationwide, as compared to, for example, cholecystitis, where the difference, the 95% confidence interval on the smooth curve, they overlap. This picture just highlights how large the difference in count was. So what we're looking at here is the incident rate ratio for April, sort of like the nadir of overall ED visit counts in 2020. And so, for example, for diverticular disease in April, there were 53% fewer ED visits. And if we look instead at the fall and winter, so what I've done here is I've created an indicator for September through December. For the most part, ED visit counts had bounced back to their baseline. So these are below baseline, but very close to 1. There's 79% as many ED visits for bowel obstruction, for example. And then there's a lot of information here in the sort of data exploration where we break it down by census regions of the United States. But there's just one item here that I sort of wanted to highlight, which is that the sort of decrease in visit counts is most dramatic for diverticular disease. And then there is this kind of, I think, interesting finding where the counts decline the most in the Northeast. So that's sort of like the place in March and April where COVID-19 case counts were the largest, New York City. And then in the South, especially New Orleans, where case counts were very high. So it seems to me that, maybe there's some correlation there as far as how bad COVID-19 is and what the change is for other conditions and ED visit rates. So this is an exploratory analysis. We don't have a patient-centered outcome. We can't address underlying differences in the incidence of surgical conditions. And then another limitation that we have at this moment in time is that we don't have race or ethnicity data. But it is sort of an interesting picture of nationwide changes in ED visit counts, tremendous declines across diverse geographic regions and with tremendously various COVID-19 pandemic outbreak, with visit counts sort of very, very close to baseline by the end of 2020. And then we do sort of see this pattern emerge where for some conditions that change in visit count is larger than for others. So right now where we're at with this is that I'm working on a manuscript revision where what we're going to do is take the 3-week moving average visit counts and kind of take what it was in 2020, divide it by 2019 to make a better picture of the seasonality and kind of summarize the findings a little bit better. And then there's another issue that we're starting to break open, which is inside these ICD-10 codes, we do have some information about complications like abscess or perforation or peritonitis. So it might kind of give us a hint about whether or not what we're looking at is a change in care-seeking behavior or a change in the incidence of the underlying pathology. So I'm open to any questions or or absolutely any suggestions about where we can go next to address what I think is a really interesting general question.
All right, thank you, Alex. We have about a minute before your next presentation. Like open to the floor. I don't see any question in the chat.
Hi, that was really interesting. I'm wondering if you, so I know that you had that, it looked like you stratified based on geographic region of the country. And you might not want to go here, but I wonder whether you looked at sort of political leanings and whether you saw any kind of trends there, if you looked at that.
Yeah, we have not, but I do think it really is a very interesting question. I would love to, inside that University of Maryland data, you know, which is, it's actually publicly available county level data, they do have this measure called a social distancing index. And so you could sort of imagine like combining that with a little bit of geographic data on political leanings. That would be really interesting to know. Definitely something for the future to see how much, I don't know, perhaps in rural or more conservative places, the visit counts didn't change as much. I don't know.
Yeah, so I mean, even I wonder, like looking at something like the how large the land area was. I think that's in census data, right? Like, or how rural it is.
Right. Yeah, absolutely. Definitely something that that's another angle that I think we need to kind of start exploring.
All right, thank you, Alex. You have the next talk. You are up again.
Yes, I will try to be respectful with my second talk, which is the same data set, and go quickly because I know it's the end of everyone's day. Okay, so we're a little further along. Can you guys see this slide here? We're a little further along with this topic. So another angle, I guess, on this big interesting question, which is what happened to acute care utilization during COVID, is if there's been a change in care-seeking behavior, perhaps it would be sort of exaggerated amongst older adults who, you know, would have more to fear from contracting COVID-19 in a healthcare setting. So this project was emergency department visits for emergent conditions among older adults during COVID-19. So there were 299,000 excess deaths in the United States through October 2020. And, you know, we were looking at one of the estimates of it, and a third of these excess deaths, this excess mortality, is not directly attributable to a COVID-19 infection. We know that ED visits for emergent conditions have declined. So thinking about acute MI or stroke. And there is some data to suggest that patients may be delaying or deferring care seeking. And then one of the things that I kind of learned about in the process of working on this project was that there are a lot of really unique challenges that come to play in how the care seeking process works for older adults. So they may be more likely to get very sick if they do contract COVID-19. Older adults have a greater incidence of time-sensitive pathologies like acute MI or stroke. And then they also are sort of more likely to be reliant on others, on caregivers, to initiate the process of care seeking. So we had a couple of hypotheses. One was that older adults would exhibit a greater decline in ED visitation rates for emergent conditions. A second was that this relationship would be attenuated for a condition that we hypothesized would be less sort of amenable to care-seeking discretion. So for that case, we used the diagnosis of hip fracture. So in contrast to an acute MI or stroke, where your propensity to seek care, you know, it depends on recognizing the symptoms of a stroke or of making the choice to respond to an episode of chest pain with a phone call to EMS. In the case of hip fracture for a patient who's community dwelling, this is a sudden, abrupt, and complete loss of functional mobility. And then our third sort of hypothesis is that older adults would be less likely to die in the ED, so disposition from the emergency department death, given their decreased propensity to seek care. So this is the CEDAR data again. In this case, this was data through November 15th, 2020. And in this data extract, we had 164 ED sites. And again, we combined it with this public data on COVID-19 demographics. So we identified 5 conditions, again, with the ICD-10 codes: acute MI, stroke, sepsis, and then separately sort of falls and hip fracture. We broke it down into 3 different age categories, so 65 to 74, 75 to 84, and then 85 and older. And then we kind of present the comparison of 40 to 64. And again, we identify a pre-pandemic period, the early pandemic period, which is sort of March and April, and then a post-early pandemic period. Outcomes were daily counts for each of the 5 conditions. And again, we plotted the smooth curve, the lowest curve, and we looked at condition-specific differences within age groups over time periods, again, using the Poisson regression model because the outcome is a count. So this is the picture that you saw earlier, but with a slightly smaller data set, giving you a sense again that these tend to be smaller emergency departments. And here's sort of the mainline picture here. What we're looking at is each line is a different age category. So for example, first for acute myocardial infarction, starting from January 2019 through November 15th of 2020. This is the absolute visit count. So you can see that for the age category of 85 plus, that's the yellow line. There's far fewer sort of raw number of 85 or older folks coming in the door with MI, but the declines occurring for all age groups are sort of larger relative to the baseline visit count, and I think somewhat more persistent into the fall than they are for the younger age categories. And you do kind of see a similar effect for stroke in the early pandemic and the post-early pandemic period. Whereas in the case of hip fracture, we're looking at very small sort of daily visit counts. The raw number is small, but it's much harder to see a clear decline that is occurring at the beginning of the pandemic. We struggled a little bit with the right way to kind of summarize this finding, but this picture right here that we're looking at, we're depicting the incident rate ratio, so that outcome from the Poisson regression. So for example, if we look at the 85 and older category for acute MI, the circle is the early pandemic period. So what this is saying is that about 70% as many ED visits for MI in that age category in the early pandemic period, and 80% as many in the post-early pandemic period. So kind of going into the summer and fall through November 15th. And you can see that when you move from the early pandemic to the post-early pandemic period, from the circle to the triangle, that bounce back in ED visit rates is much smaller for older folks than it is for the younger age categories, both for acute MI and for stroke. And this was part of the hypothesis, would be that the change in care seeking might be more durable in older folks, would be sort of a greater risk of delaying care late into the pandemic. And that's kind of what we're seeing here, is even in the post-early pandemic period, there's still 80% as many ED visits for these conditions. When we look at deaths in the ED, so what's the ED visit count for patients of different age categories who actually died in the emergency department? What we find is that in the early pandemic period, those numbers are much higher, and not uniformly statistically significantly higher. And then this effect kind of reverses in the post-early pandemic period, and we get a much smaller percentage of people arriving in the emergency department and then dying in the ED, especially in the oldest age categories. So somewhat similar limitations. We don't really have a patient-centered outcome necessarily here. There are limitations around the ICD-10 diagnosis coding. So those aren't necessarily 100% reliable or a perfect sort of indicator of the underlying pathology. And then again, we don't actually yet have the underlying differences by race and ethnicity, which I think would be really interesting. But the conclusion here is that there are large declines in ED visits for emergent conditions, and those declines are larger for older Americans and more persistent for older Americans, which I think is just the results is sort of telling us that we should be concerned both now and in the setting of future pandemics about keeping that relationship between older Americans' pathologies and their ability to access care really, really strong. And these were some of the themes that we sort of talked about in the discussion of the paper, but your connection to family and caregivers, your ability to have symptoms be recognized, your ability to get to the emergency department, your level of concern about contracting COVID-19 conditional on coming to the ED, with the caveat that we can't, with this data, see a true decline in the incidence. So it is also possible that there were simply fewer heart attacks among older folks during COVID, but that's sort of one of the limitations. This was a manuscript that came out just a few days ago in the Journal of American Geriatric Society. And then the kind of next step that we're working on right now is combining some of the data that we have about COVID-19 and social distancing to do a more sophisticated spatial temporal analysis of ED visit trends for some of these conditions that are emergency care sensitive, where timely care matters a lot. And that's all I have.
All right, thank you very much, Alex. We have about 2 minutes. If anyone has any question for Alex. And congratulations, yeah, for the journal that was published. I saw Dr. Arjun Venkatesh share the link on the chat.
Alex, I'll make sure to read the paper, but while I've got you here, I was just wondering how you defined early pandemic versus kind of post-early pandemic, and did you see that at least any like announcements from CDC or guidance that happened in particular area, like in those phases that would maybe lead to that durability and or release of data in our understanding? Just trying to get a sense of how you determine those definitions. Thanks.
I really struggle with, there's lots of like arbitrary decisions and research about how you like do the analysis. And this is one of the ones that I struggled with, but the way that we did it for this paper was the CDC actually has a defined time period that they call the early pandemic period. It's, I think, March 25th to April 29th, sort of predefined. And that was based on data about when COVID-19 caseloads became sort of relevant from a health systems perspective. So we just used their canned definition. But there's lots of other papers on this general topic, and many of them have different answers to the question of like, how do you meaningfully break out the time frame? I don't have a really good general answer to that question.
Thanks.
Hi, so that was really interesting. Thank you. I was wondering, I know I know that you controlled for COVID-19 levels, but I was wondering if you have tried stratifying. I mean, I'm wondering if maybe there could be a story about people's fear, sort of. So if cases are, if you're in an area where caseloads are higher, maybe you're even more afraid to go in.
Yeah, this is also a really interesting general question. Arjun Venkatesh, who I think is also on the call, he and I did an earlier paper that was in Annals of Emergency Medicine, where I think maybe we did a better job of this, but we did do like the breakdown by US Census regions. And we did it even more granular. We did it by state as well. So we like plotted what the ED visit counts were, on like one y-axis, and then on a second y-axis put how bad COVID-19 caseloads were. For that paper, we didn't have the stratification by age, but one of the things that we found was that the the drop off in ED visit counts for emergent conditions for heart attack and stroke, things like that, is like surprisingly uniform despite the variation in COVID-19 caseload. Like if you look at New York City is like really well represented. We have lots of EDs from New York City in the data set. The COVID-19 caseloads, go up, and the total ED visit volumes declined by 60%. That was like the number, but it's still 40% even in, Oregon, where COVID-19 caseloads were not nearly as high in March or April. So I have this theory that we're mostly responding to like the national news media. Like mostly people see, I don't know, they see a picture of what's happening in New York City and they go, oh, I guess I'm not going to the ED today. I don't know how to do it in a more sophisticated way though. Like one of the things that I'm kind of struggling with is like, Arjun is kind of connecting me with the right people so that we have a statistical approach to dealing with all those things. To take a more sophisticated angle on it, I guess.
Well, I wish I'd have an answer for you as the moderator, but I don't. So I think it's still up for debate and just have to define the way that you do the analysis at this point. Unfortunately, there's no consensus, I guess.
Yeah, thank you so much, guys, for hearing my story and lending your thoughts.